Well, thank you, Kay. I greatly appreciate that introduction. And thank you, participants, for taking time out of your busy schedules to join us this afternoon with the Colorado Academy of Family Physicians. The title of my discussion today is Extreme Makeover, EHR Edition, and it's a distillation of a story I told in Orlando last year at a meeting called HIMSS, where Health and Human Services Secretary Kathleen Sebelius and about 20,000 other individuals were able to watch a 2-minute video about Miramont and what we're doing here in Fort Collins, Colorado. And then 5 of my partners and I received the HIMSS Ambulatory Davies Award, which is given basically to ambulatory clinics that have the best in information technology in the entire United States of America. So we obviously were very humbled, proud, and pleased all at the same time to win the award. And I want to share with you how we did it. So there's no real apparent or conflicts of interest to report. Our learning objectives today are to recognize how NCQA recognition makes it possible to improve safety, efficiency, patient outcomes, and profitability in the ambulatory care environment, to illustrate the link between NCQA recognition and a successful meaningful use implementation strategy, and to summarize the business case for improved clinical quality metrics, aka registry reporting. And I'll explain all those in more detail. So who am I? Well, in 2002, my wife and I moved back to Fort Collins, and we bought one of the oldest practices in Larimer County. Guy had been there for 30 years. He bought from another guy who had been there 30 years, who bought it from a guy who found it in the 1940s. It was open most days of the week. They were closed Tuesday morning and Wednesday afternoons. He had paper charts. He still went to the hospital some days. He had one employee, and he had one computer. It was a little 386 IBM compatible, if you remember those. And there were about 1,000 active patients, although he left us about 3,000 paper charts. And here's a picture of Gordon and Jean. She ran it as the practice administrator, kind of a mom-and-pop shop, the traditional cottage industry. But they really weren't doing anything different than they had been doing in the 1970s. I mean, it was kind of like frozen in time. And so I found myself in a basement with paneling on the walls, and we started adding staff. I had a PA and a couple other staffers, as you see in the picture there. But we were still stuck in that 1970s mode. We had walls of paper charts. We didn't really have any way of managing our metrics or knowing whether we were producing a quality product day after day for our patients. And so this PowerPoint typically has a bus that moves across the screen, but because of the technology, it's just going to flash to the next one. But if you've ever watched Extreme Home Makeover, you know they have this bus, and then they move the bus, and the people get to see the new house that's been built for them. So I'm just going to move that bus and take you to the year 2012. And this is our data center, and it just kind of represents the epitome of what Miramont has accomplished in growth. We've got terminal, here I'll bring my pointer here, we've got terminal servers here. They're 1,000 gigabytes each with hot swappable mirrored hard drives. We have voice over IP, so we can call China for the cost of going to a website in China. I think our cost is $25 a month for long distance. We have a fax server, so it's paper on their side, but on our side it's PDF files, and we're sorting them electronically on a desktop and signing them in an electronic or virtual inbox and sending them back. And then we also have a PAX server for our X-ray. So in 2012, we've got 4 locations in 3 separate communities: Parker, Wellington, 2 in Fort Collins. We're open Monday through Friday, 8 to 8, Saturdays 9 to noon. We have 14 providers, 50 employees, electronic charts, a patient portal where our patients can come in, look at their labs, see their chart, make copies of it electronically. They can send me a HIPAA-compliant email. They're able to schedule appointments. We have our NCQA Level 3 patient-centered medical home recognition, 80 computers operating on that terminal service environment, centralized data center that I just showed you. This is supposed to say 25,000 patients. I left a number out there. My apologies. And then we have the ambulatory Davies Award recognition from HIMSS in the year 2010. The Northern Colorado Business Report says we're the 4th fastest growing company in Northern Colorado. That was both 2008 and 2010. Not clinic, but company, doubling in size every 2 years. They're growing at 34% per year, and that's in this economy. You can see from our growth curve, Carlson's last year in business, he had about 169,000 in sales. We just finished our taxes, and I think we're going to be about $4.5 million in sales in the year 2011. So Miramont has literally, it's been an explosion over the last decade. Here we are in Orlando with the Ambulatory Award. And in 2011, the Colorado Academy of Family Physicians Foundation named us the Patient-Centered Medical Home of the Year. Now, during the same period of time in Fort Collins, we had 34 primary care doctors shutter their doors because they could not make it economically sustainable. I'm not talking about retirees. I'm not talking about people like Dr. Carlson that I bought out who was 69 years old and needed to retire. I'm talking about individuals like Jim Bush, who's 50s, an internist. He said he just didn't want to do it anymore. He was making half what he did previously, didn't feel he was taking good care of his patients, and he took a job with Medicaid, and he sold us his practice. 8 of those 34 were actual bankruptcies, where physicians literally had banks or other parties come into their office and repossess equipment while they were doing clinic, and that was basically their last day in clinic. And then hospital movement. In the past 4 years, while we see these drawdown in primary care, the number of ER doctors has doubled in my county, and ER utilization increased by 50%. And in the past 2 years, 169 physicians became employees of the local-owned hospital medical group. And there's only 600 physicians in the county, so we're talking 1 in 4 said, I give up. And these aren't just primary care. These are cardiologists, neurologists. They're just saying this just isn't sustainable anymore. Now, I'm going to go back and explain to you a little bit about why Miramont's been able to continue to grow despite these horrible economic pressures. Let's go back and look at our product in 2002. Our test results are slow. Labor costs are high. They do a lot of non-revenue generating activity and waste. I have no open appointments. There's no clinical data management, barely any financial data management. Patient experiences are variable day to day. Some days we're open, some days we're not. They never know. Documentation's illegible because we're in paper, and I have the worst handwriting in the company. And we're unable to compete with retail clinics, urgent care, emergency departments in the hospital. We just feel all those pressures. And so my partners and I met, and we decided that we were going to have to do something different to get out of last century. So we hosted a company retreat in August of 2007 up in Estes Park. That was a remarkable year for me. I'd been elected president of the Colorado Academy of Family Physicians. And Estes Park is only about 60 minutes up the road, and I thought it might be nice just to bring a bunch of my staff up there with me. And we attended a workshop with Len Frommer, and we'd started thinking about the Health Teamworks pilot that Margie Harbrecht's group was convening and the opportunities for us to be a pilot practice. And we decided that we would do a 2-day retreat, and we were just going to get it out on the table and figure out what it was we were going to have to do to be solvent, to not be the next practice that bankrupts or that folded or became a hospital employee. And I put this quote from Proverbs 29:18, where there's no vision, the people perish. This is really about leadership, and it's about physician leadership in ambulatory medicine, making the decision that we're going to do it, that we're going to survive. And so we came up with a positioning statement. We decided for local families desiring health care that Miramont Family Medicine would be the choice that offered the most convenience and the highest value. We decided that we were going to put ourselves in that position. And we also made a mission statement to deliver compassionate, modern, timely health care in a clean, professional environment that promoted patient and staff growth, health, and happiness. Because we wanted our staff to be happy also. And we decided that the process was going to start with investing. And I'll tell you the story I told the physicians who attended that meeting in Estes Park 5 years ago. I gave the analogy of bad food. And I said, we're here doing the same things we were doing in the 1970s. We've got our paper charts. We're not looking at quality metrics. Liken it to if we were in the restaurant business and we had bad food. We could not just raise the prices on our bad food to get the capital to buy fancy cooking equipment for our kitchen or to hire a really good chef from Chicago, could we? I mean, no one's going to pay more if the food's bad. And yet how often as physicians do we do this? We go to the insurers, we say, well, you're not paying us enough. But the insurers look and they go, your product's horrible. We're 37th in the world according to the Institute of Medicine, just a little bit better than Bulgaria and a little bit worse than Costa Rica. I mean, they want something for their money. So we decided the process started with investing. We made friends with the banker, the accountant, the attorneys, and local business leaders, just like any other small business would do. And we pledged that we would make Miramont safer, more efficient, and up to date. We would ensure our own profitability at all times, not because we're profiteering off our patients, but because that's what's required for us to really be of any use to them. If they're going to have a long-standing, trusting relationship with a family physician, then we have to be there year after year. We can't bankrupt. We had to eliminate as much as possible non-revenue generating activity. We had to find ways to provide needed services in-house, in the free market system that we're given. And we wanted to find a better EHR because at the time we were on a legacy product the hospital was giving us for free, and you get what you pay for. and we decided we were going to have to invest. And probably most importantly that day, we decided that we were going to attain NCQA recognition for patient-centered medical home. And the process of gaining NCQA recognition, I cannot underemphasize how important that is, because it forces the physician and the rest of the team to redesign your entire workflow. And just going through the process of getting NCQA recognition eliminates waste, it improves efficiency, it makes you more profitable. So let's talk a little bit about quality and meaningful use. Our federal government, through the HITECH Act, which President Bush signed into law, says they're going to pay every physician $44,000 for using an electronic health record. But it has to be implemented in a way that they call meaningful. There's 10 core set and 5 menu set criteria that have to be followed. And it follows a lot of the basic tenets of the patient-centered medical home model. It really requires a physician leader who's willing to lead the team, although every person on the team can be empowered to contribute to the process and improve workflow design. And I have delegated so much more to my medical assistants, my reception team, than I ever used to, and it has actually made us more powerful as an organization and been the right decision. And we looked at the Toyota production model. Now, if you're not familiar with the Toyota production model, the Toyota way is built on these 2 pillars of continuous improvement. One is called Kaizen, and the other is called respect for people. And I'm going to explain why this is so important. Toyota has become the dominant auto manufacturer in the world, overtaking GM. And they did it coming out of World War II on the heels of, Nagasaki, Hiroshima being bombed, a broken economy, and yet 50, 60 years later, the 4th largest economy in the world, and Toyota being one of those important ingredients. One of their tenets is the PDSA cycle, the Plan, Do, Study, Act. And what this involves is planning is just stating the problem that's going to be addressed. So, like, we might look at a process and say, how many steps does it take to give a vaccine? If I have 2 medical assistants and one of them can give that vaccine in 10 minutes and the other one takes 15, one of them is clearly more efficient than the other, because the one can do 6 of those vaccines an hour, the other can only do 4. And if I'm paying them both the same amount of money, and yet let's presume that there's a small amount of profitability in vaccines, which is not always true, but it can be done profitably, and we can talk offline about that if someone's interested, then one of them is obviously generating revenue and the other one's not. So we would start looking at, well, are all those steps necessary? And then we would look at an objective and say, why don't we figure out what's really necessary with giving vaccines and what's not, and we're gonna see if we can eliminate unnecessary steps. How many times we're recording it, giving the patient a shock record, we're putting in the paper chart, we're going online and filing it with the Colorado Immunization Information System, and we start saying, okay, what will our electronic health record do? And then we're gonna select different metrics to follow. Maybe we'll actually time and break out stopwatches. And Miramont has done this. We've done this for 8 years now, where we break out a stopwatch every now and then. We pay someone to stand there and just time people and see what the process takes, and then look at and get some data. And then we finally look at the data a final time. We study it, because sometimes our initial assumptions were wrong, and what we thought was the holdup turns out not to be the constraint, and it turns out that there's something else that's the problem. And then we take that information and we reinvigorate ourselves. We go back to the beginning of the process, kind of like a circle, and say we're going to do another test cycle, and we decide we could eliminate these 2 steps, and now we're going to shorten the cycle time and see if we can be more efficient, safer, have less waste. And then continuous improvement is another important tenet of the Toyota production model. Now, at Miramont, we call this constant change brain damage, and I'll tell you, it is a lot of work. I've lost employees over it. When I broke out an electronic health record, I had staff quit. I had a particular staffer, I remember, 50 years old, didn't like using computers, and didn't use them at home. Job just didn't work out. I've had other staff come in, and they don't like constant change. We say, well, we're going to try this now. Now we're going to try this. But honestly, the majority of my staff are not burned out. They're burned in. And even our customers over time have come to realize this not as constant change, which, of course, people hate change, but as progress. And they get excited about it and come in wanting to know what's new at Miramont. And that's really what we want the customer from a perspective. Respect for all people. This, again, goes back to empowerment. Are you letting your MAs and receptionists be all that they can be? Toyota has this switch in their production line. If there's any employee on the production assembly line who sees a problem with quality, like they see, oh, wow, that part's being put on backwards, they can throw a switch and stop the entire production line. That's power. I mean, Toyota's investing millions per day in being able to produce a number of cars per hour. And if someone can shut off that switch and shut that down, that's extremely expensive. But Toyota U.S. President Yoshio Isazaka says, we allow it. And this goes back to the respect, because they trust that person. That person knows what they're doing in your office better than the doctor does. I don't go to my receptionist and say, hey, that's not working, here's a new plan, because I don't know her job or his job. I go to them and I say, what do you think the problem is? We sit down, they join us in the meetings, and we start cycle testing it till we come up with a way to solve it. Another respect for all people is the timeout. You know, the hospital equivalent where the hospital in the OR, you know, they now say, are we operating on the right leg or the left leg, and they check it. Is there an ambulatory equivalent? Well, we came up with one at Miramont. We have our MA check-in list here. This is kind of like what a pilot uses before taking off, you know, or landing the airplane. They want to make sure the wheels are down, that they don't land without wheels. And you can see that the checklist is written in different colors. The red ones are there because, honestly, they're written in blood. I tell my staff, how does Miramont kill people? And I say that a little facetiously, but, you know, I can tell you stories of people who've come in and they missed a vital sign, or someone had a tachycardia of 130 and the doc didn't notice it, the MA didn't say anything to the doc, patient's diagnosed with a cold, 2 days later they're in the emergency room or in the ICU with a pneumonia. And I tell my MAs, this is how you save lives. You make sure that you've always got these ingredients here, and you go through your checklist and you don't skip steps. The blue make us more efficient, the green make us more profitable. And then they're expected to use their checklist as a safety device. The other thing is wisdom of crowds. Now, there's a gentleman by the name of James Surowiecki, and he has told us in his book, The Wisdom of Crowds, that the group will give better advice than an expert or a guest. And he uses a couple illustrations for this. One of them is if you go to the state fair and they have a large oxen for bid, and people are guessing the weight of the oxen as part of a contest, it turns out that if you take those 1,000 guesses and you average them up, it almost exactly is the weight of the cow. In fact, it's so reproducible, it's almost kind of freaky that 1,000 different people looking at the cow as a group will know how much that cow weighs, even if individual people don't, because the ones who way overguess tend to adjust the ones who or compensate for the ones who underguess, and they end up having an average that sometimes is even closer to the weight of the cow than the actual closest guess of an individual. Another proof he gives is if you watch the hit television series Who Wants to Be a Millionaire. You have 3 lifelines in Millionaire. You can phone a friend, you can ask the audience, or you can do 50-50. What is the best lifeline? Well, if you use 50-50, you only have a 50% chance. And if you phone a friend, it turns out that's kind of like asking an expert or bringing in a consultant. They're right only about 60% of the time. But if you watch Who Wants to Be a Millionaire, if you poll the audience knows the correct answer 92% of the time. They get an A. Only 8% of the time is the audience wrong. So empower your staff. Ask them the question, and as long as they have all the information, they'll give you the right answer. It's not science. Well, it is, but it's not rocket science. Now, some other things Miramont did, we took a lot of big jumps. I leveraged my house, and we put $1.4 million on an SBA loan where I put $140,000 down. We built a new building in 2005, and we started bringing new products and services. I added a female provider in 2002. I added a lab in 2003 so we could do cell counts and chemistries. We started bringing in visiting specialists. We built the new building I just showed you. We added X-ray, physical therapy, in-house psychotherapy, ultimately transitioning to psychology, after hours. We started doing nerve conduction studies in Saturday clinics and a female physician, colposcopy. We brought in a pain management specialist. And these visiting specialists pay me rent, and in return they see our patients, and it works out really well. There's so many cost savings because now the patient knows where to come. We don't have to give them a map. They trust the specialists that we bring in. They never ask me, do you trust this person? They just presume that we vetted them because they're in our clinic. We don't have to make copies of the charts or do prior authorizations because we tell our specialists they have to take the same insurance we do, including Medicaid, because we see new Medicaid. We added a dispensary, which is a pharmacy. We got that patient-centered medical home recognition. We built a new website. We started a program called the Miramont Value Plan for people without insurance so that they could get rock-bottom pricing, just like if they're going to a retail clinic. We can charge them $64 for a visit, etc. We started doing some laser aesthetic medicine and Botox, brought in some digital mammography, built a drive-through pharmacy in 2011 up in Wellington, doing fluoride dental treatments for kids because Medicaid wanted us to do, started doing health information exchange with our regional information office. I have a little data here about why it makes sense to do a lab in-house, but without going into a lot of the discussion, Dr. Carlson, who we met at the beginning of this, his old model, they didn't even draw blood in clinic. They'd send them out to an express lab, and they get their labs drawn, and sometimes they went, sometimes they didn't. They get the result back 2 days later with a paper chart. 40 patients later, trying to remember why we ordered the test in the first place, call, get a voicemail, spouse calls back, don't know if that's, someone we can talk to because of HIPAA. And the value-added team, when we measured this, it took 20 minutes of MA time on average to do all these different steps just to get a patient their result. Now in our new model, I order the test, and before the patient can even say no, my MA's in there, drawing their blood. It takes us 10 minutes to run a cell count and to report it back. I go in, and sometimes I've had surprises. I've literally found people, just happened last week, a hematocrit of 5, was not expecting it. The guy was there for routine lipids, said, what's my blood sugar? We checked his sugar. It was high, so we checked an A1C. Machine said, can't read the A1C because his hemoglobin's too low. Checked a hemoglobin, it's 5. He's 93. He doesn't feel weak, but I admitted him. I transfused him. Turned out he had a duodenal ulcer. And so, in our old model, I would have done his lipids. I would have ordered the blood sugar maybe, and I would have gotten that result 2 days later. It would have taken me another 2 days to get to the CBC. He could have been in the ER by then. And so we prevented him maybe being an ICU admit and made him just a regular floor admit, saving the system thousands of dollars. And plus now my staff, because it only takes them 10 minutes to do the cell count instead of 20 minutes to do all those other steps, they have more time to do revenue-generating activity like spirometries, EKGs, serum irrigation. Dispensary, same thing. We sell $6 generics. Our Zithromax we're able to price less than the Walgreens and Walmart and the other big box stores. And we can adjudicate it with all the PBMs. So the patient will say, well, I get it for $5 at Walgreens. Well, they get it for $5 with us, too. They just show their card. We adjudicate with Express Scripts and the other plans. And we collect the $5, and then we get the other $14 in the mail and something like an EOB a couple weeks later. Now, here's Paul Grundy. Paul Grundy's the medical director at IBM, and he had a vision. He learned about 10 years ago that IBM could not produce computers in the United States as efficiently as they were in the tiger economies of Malaysia and Thailand. And when they looked at the problem, it turned out it wasn't because the manufacturing costs were that much higher. It turns out copper and fuel actually cost as much in Thailand as they do in the United States. In fact, fuel costs more in Thailand than it does here. The real difference for them was the labor. And when they looked at the labor, it was primarily the healthcare costs. And not just the healthcare costs for their current patients or their current employees, the healthcare costs of those legacy costs they were paying for the employees that used to work for them in the 70s, 80s, and 90s that they said, hey, we're going to pay for your healthcare and we'll be your Medicare Advantage plan, et cetera, et cetera. And Paul Grundy went to the top 5 insurers, Aetna, Cigna, Blue Cross, Humana, United Healthcare, and said, look, this product is crap. You guys, you're selling us bad food, right? We're 37th in the world. We want you to support the patient-centered medical home model. We want you to pay per member per month fees to primary care physicians. We want you to pay for performance. And guess what? The insurers said yes. They said, we will do this. Now, IBM is the 4th largest employer in Colorado, so they brought this together under the auspices of the Colorado Multi-Payer Patient-Centered Medical Home Pilot Project. And Health Team Works, which was previously called the Colorado Clinical Guidelines Collaborative, became the central convener. Margie Harbrecht's group accepted 200 applications. Miramont was positioned. We had that retreat. We'd done our NCQA steps. We were ready to get the level 3 recognition. We had our EHR online and running. We applied. We got accepted. And so we were able to start doing that patient-centered medical home. Now, what is a patient-centered medical home? A lot of family physicians, they say, well, I've got a patient-centered medical home. But do you really? If you don't have the NCQA recognition, you're probably kidding yourself. I was kidding myself. There were a lot of things I thought I was doing. Turned out when we started having to fill out the reports, we didn't meet the criteria. Now, when we finally did apply after we had gone through them, we scored 96 out of 100 possible points. So we did our homework and we prepared. but there's pre-implementation planning. I huddle with my staff every morning before I start clinic. We go through and say, okay, this person's going to need this, this, and this. This person has a pop-up saying that they owe a past bill. Make sure reception gets that taken care of, because I don't want to do $200 more in business here and then have them go to collections, because they can't pay for it. We need to figure out some other ideas. We talk about this person needs fasting labs, call them. This person's probably going to cancel because I just saw that they got admitted last night to the hospital, so they're not going to make that appointment. Let's open that slot up. And we take care of all those little inefficiencies that otherwise would build up during the day, so that we're able to take walk-ins and do other things with our schedule that maybe others aren't, that we weren't able to do otherwise. And then EMDs is our electronic health record. There's very good EHRs. We won the Davies Award with EMDs. I think they're one of the best. This, again, just shows us doing our daily backups of term server and data server with our IT. Intuit Health, formerly MedFusion, Intuit maker of QuickBooks, bought MedFusion. They're an AAFP affiliate. They do our website. They do a great job. We have links on our website to the patient portal. If you go to www.miramont.us, you'll see what we've got. Patients can pay their bills online. They can access self-help charts. They can send us emails. We've got 65,000 hits, I think is what the stat counter shows us, so it's very heavily utilized, and that's the website there. And then this is just some more information showing us the home page where the patient can click on the patient portal, or they can go to the other various links. And on the patient portal, they can make an appointment, and they can submit registration forms. They can look at their labs and do all kinds of things. That, again, instead of it being a phone call, now we've got asynchronous communication going on, much more convenient. A lot of younger people particularly like it, but even a lot of our seniors really get into the portal if they have a computer at home. Putting in an EHR reduced our transcription costs. We have stronger reporting capabilities. We can renegotiate with insurance payers because now we know what we're doing. We can show them how we're saving the money. We were able to directly interface with our practice management. That helped with the charge capture. So now if I order a lab, it's being charged as I order it. So in the old days when I had papers, sometimes I was ordering them and then we weren't collecting because we forgot to bill. Clinical outcomes, we're able to manage population metrics. So we can look and say, wow, we do really good with tobacco screening, but we do horrible with A1C testing. What can we do? Well, let's add an A1C machine. We'll start testing them in-house. Let's get a report out each day that tells me in the huddle which of my patients coming in are diabetic, need an A1C. Maybe they're coming in for a sore throat, but we're going to surprise them and say, by the way, you need your A1C. They're going to get drawn before I even go in the room. By the time I sit down, I got that result. I see it's 7%. We're going to talk about that in addition to their sore throat and get something started and have a close follow-up. We finally know how many diabetics we have. And I apologize. This is old data. As you can see, it cuts off at August 2010. I actually do have data through January 2012 now. But we're well over 370 diabetics. And, when I was in paper, I had no idea how many diabetics I had. That kind of information was transparent to me. I'd have to count all the charts, and then if someone came back and said, okay, how many have reached their A1C goal, I'd have no idea. But now we know. We know that, 95% of our patients that are diabetic have had an A1C check. You can say, what about the other 5%? Well, sometimes, there's confounders. Maybe a person came in and they had the wrong insurance. We had to run their lab with a lab core or something like that because we can't get their labs done in-house, and then the patient never came back or never went and got done, so there's some of those idiosyncrasies. I point those out to the payers. I say, if you let us just do them in-house, we could probably get that last 5% off there for you. It's up to you, You can pay LabCorp, you can pay us and get better outcomes. Managing population metrics for chronic disease now became realistic because we could see our numbers improve, and I published these. We put them in our nurses station. Every staffer knows what our metrics are, and then I pay productivity bonuses based on our metrics. I say, if you want your performance bonus this month, yeah, we still need to see 50 patients per day averaged over 4 weeks. There's a little bit of volume demand still because we are getting fee-for-service dollars. But I also want you to make certain that we're at our metrics goals. If our metrics slip, if we start producing only quantity but not quality, people aren't going to get their bonus this month. And it makes the staff really pay attention to those metrics and get engaged on how they can help play their part to keep those metrics improving. We eliminated illegible handwriting, obviously, within EHR. We improved our documentation of phone conversation and now electronically as well. No one's searching for paper charts. We eliminated a lot of paper waste. We have scanned and shredded 12,000 medical records. I don't have any records in a basement. Basically, if they're 7 years older, we shredded them. and if they were 7 years or less, as we grew and expanded and other practices joined ours, we scan and shred the records. It takes 6 months, to scan a physician who's got 3,000 paper charts. But we work on it each day. Here's the reception team member at checkout. She's got the Fujitsu high-speed scanner. It's duplex, can do two-sided, even color, 120 pages per minute. I mean, it's fast. Turns it in a PDF file. We've got the data forever. The value-added team I spoke to you about, they came out and they measured our processes with their stopwatches, and they said from paper to computerization, we improved our value-added time by 3%. Now, that doesn't sound like much, but remember, this is for like 20,000 people, which is huge for most businesses. And so value-added time is basically the time where the patient is in your office and they're getting something out of it. So if they're getting their blood pressure checked, or they're filling out a form, or the doctor's talking to them, or they're getting their blood drawn, or they're getting some counseling, that's all value-added time. If they're sitting, reading a magazine, that's waste. And so what it's saying is that previous to implementation, about 36% of the patient's time was waste. Now we've cut it down 3%, and we just keep eking. And this is 2007 data. I think we're actually doing even better by now. This shows you a value stream map. The Carl Foundation for Medical Care prepared this for us. You can get a hold of them. They're in Boulder. You can Google them. Ellen Batchelor's group at the time. And it just shows all the different steps our patients go through when the MA evaluates them. Here, I'll get the pointer. MA evaluating them, MD evaluating them, the checkout. And then the average value-added time and the percent value-added time. You can see that it was at 64. It's pretty small print. I apologize for that. And then you can see after implementation we went to 67. So we were able to get data. We knew that we had improved with the EHR implementation. The other thing the Computer Data Center gave us really was the advantage of being able to externally report our metrics. Now we could go to payers and different projects and say, look, we've got all this data. Do you want it? We'll report it to you, and we'll do it in a HIPAA-compliant way. So one of the things we did, of course, is the patient-centered medical home pilot. I told you that we're one of 17 clinics to participate. 2 of the clinics have since folded. We acquired 2 of them, and so now there's just 15 clinics left. In 2009, we had an extra $50,000 in per member per month fees. In 2010, $85,000, well over $100,000 last year. I don't have the exact numbers because we're still doing our taxes. DartNet, this is a program that's done through the American Academy of Family Physicians, Wilson Pace's group at University Hospital. They said basically report data to us on depressed patients and we'll pay you some money. And we said, great, we'll do it. Medicaid, they said we'll give you an extra 10%. When you see Medicaid children, if you report data to us for a Colorado Immunization Information System, they call the program CCHAP. This is a program that virtually every pediatrician in the state participates in. Not very many family physicians do. I don't know why. We're eligible. A lot of family physicians don't know about it. See Medicaid kids. It's a great way to build your practice. Medicaid kids don't stay Medicaid forever. They grow up, they get jobs, they become insured. And it's a good way to keep peds in your practice. And if you get CCHAP, you get a little extra 10%, and that's almost the same as Medicare at that point. So if you're proper with Medicare, you can be with Medicaid. This is Bill Ritter, our former governor here. He's signing the Colorado Immunization Information System bill into law. This is yours truly behind John Bender here, and then Raquel, at the time Alexander, now Rosen, the EVP of CFP. And basically, Miramont worked on that initiative to get that centralized database, and we were the first private clinic in the state to report our metrics electronically. So my staff didn't have to sit on a computer and hand type them in through an online web session. We had a scripting routine that our EHR vendor wrote that automatically took the data and pushed it to SIS and populated their database. PQRS, it used to be called PQRI. We worked with a company called CINA, the Clinical Integration Networks of America, for $5,000 a year. I pay them. They mine my SQL database in our data center, and they report all our data to the feds. We get our formulary bonus and our PQRS bonus. Bridges to Excellence, this is Donna Marshall's group with the Colorado Business Group on Health. They pay us a little bit of money. It's not much. It's chump change, but every little bit. I mean, I'm already reporting, and so to report to them doesn't cost me anymore. I just tell CINA, hey, report to them also. And we get a little $1,200 check every quarter for having excellent metrics on heart stroke and on diabetes. Meaningful use, we were either the first or the second. I don't know. It depends who you talk to. I've heard different things from Phyllis Albritton and others. But we were first or second practice in the entire state to get paid meaningful use monies in May of 2011. And we've already done our attestation for 2012, so we're ready to get the second round of checks. Here's some of that data showing, AR management and accounts receivable, and then over time, charges growing. And this is a little spreadsheet. It's basically a profit loss showing our 71% return on investment. So that first year we spent $134,000 in IT. Remember, we invested this ourselves. We didn't tell others, hey, pay us and we'll do it. We did it ourselves, and then the money came in. We brought in $231,000. We had a 71% return on investment that first year, just because of improved efficiencies, improved safety, better productivity, ability to handle larger volumes of patients because we were more efficient. And then later we started seeing the monies come in from those different payer sources that I shared with you. Annual ongoing costs, we do have them. Now this is some older data. It's $43,000 then. I actually probably spend about $90,000 a year on my data center, but is it worth it? I've already showed you I bring in more than that in some of the incentive payments, and so we have ongoing return on investment as well. IPIP is improving performance in practice. These are our coaches. Our coaches are through Health Teamworks. We get them through Margie Harbrecht because of our participation in the Health Teamworks pilot. But in a moment, I'm going to tell you how you can also take advantage of them. For a while, they were limited by funding, and not everyone can take advantage of it. But everyone needs a coach. And just like I tell my patients when I'm trying to get them to see my diabetic nurse educator, they go, I don't need to see her. I already know everything I need to know about it. I ask them, does Lance Armstrong know how to ride a bicycle? Because, he has a coach. Does Tim Tebow know how to play football? Some of you might question that after seeing the game with the Pats, but we've all seen him play some very excellent games of football that really get the Broncos people charged up. And I'm a Broncos fan. I love to go watch him play. But Tim Tebow has a coach. It's not that he doesn't know how to play football. It's not that Lance Armstrong doesn't know how to ride a bicycle. If you're good at what you do, you will get a coach, because that's what makes you a professional. If you are doing it without a coach, then you are an amateur. You're not doing as best as you can. You don't have accountability built in. You need that external. And coaching is not free, but you can get it for free if you know where to look, or you can get it at a very good price if you know where to look. And I'm going to tell you a little bit more, because the IPIP team, this was our original coach here, we've gone through a couple of coaches because we've been in the program for so long now, for a number of years. But the coaches have just done fantastic. They come into our meetings. They tell us what, we're doing wrong. They give us feedback, and we listen to them and we implement it, and it makes Miramont stronger. And you can see that it's paid off. We've been able to build new locations. Cheyenne Regional Hospital lost $500,000 in Wellington in 2008. They closed the town's only clinic. And I'll tell you, Governor Hickenlooper is not going to build a clinic in Wellington for the 5,000 people that live there. President Obama is not going to build a federally qualified community health center there. There's no money to do that. But Miramont was able to come in as a private practice family physician group with 5 physician partners, just eking out an existence in the lowest paid county in the state. I'll tell you, Larimer, the average family physician only earns about $105,000 a year, whereas if you look at Grand Junction, the average family physician, according to the Department of Labor statistics, earns about $220,000 a year. The difference is because we have the Quality Health Network and Rocky Mountain Health Plan in Grand Junction, and they're sponsoring and paying for primary care. So as a primary care physician, the difference between evolution and extinction is figuring out how to get that quality data and that safety working for you and not against you. And then this is our building when it was not quite complete. We've actually finished it in Wellington. It has a drive-through pharmacy, a dispensary, lab, x-ray. We've got a visiting specialist, a psychologist, and physical and occupational therapy, an audiologist. I have a pediatrician now on staff who goes up there a half day a week, and I've got an obstetrician who comes up and sees patients a couple times a month. And we just are getting ready to celebrate our 1-year anniversary, and it's sustainable. They only have to see 18 patients a day. We're doing that, and where the hospital is not able to do it, the small family physician was. So we're investing heavily in our future. We're building our patient portal, our website, and I invite you to take a look at it. And don't just do it for the meaningful use dollars. I tell you, the $44,000 is not enough. You've got to do it for all the other reasons to really see the return on investment. We're starting to do some YouTube things. We're working with our RIO to do health information exchange. We were awarded a $150,000 grant through a program called ACT to put in patient self-checking kiosks. We were able to make the business case. that we would be able to collect better data if our patients were checking themselves in rather than through a reception team member. Now, we'll still have receptionists. I mean, they're going to be there kind of like if you've ever flown and you go to check in at Southwest, there's an attendant there. They help you. But our patients are going to be scanning their own insurance card. They're going to swipe their own credit card and pay their copay. We're going to do some instant eligibility checks, so we'll know what their copay is with a bidirectional interface through Gateway, our clearinghouse. And then we're going to hit the patient up with a PHQ-2, and they're going to ask that. And if they score positive on it, we're going to give them a PHQ-9 and screen them for depression. And we're going to get our depression metrics up, and if they're positive there, we're going to put them in with our in-house psychologist. And so we're really excited about the project as a way to bring that integrated approach. And it's also going to help us with collections. I don't know how many of you have to have collection parties, or you look and send people to collections because they can't pay their bill. Most of the time when we look at it, it's usually because of mistakes on our side. Someone forgot to collect a copay, patient didn't pay their copay. We then assess a $25 charge because they didn't pay their copay at time of service. Now they're mad at us because they have a $40 bill when they were only supposed to pay $15 originally. We tell them, sorry, it's your responsibility, it's your agreement with the contract. But, the reality is if our reception team member had remembered it and had pressed them at that time, they probably would have paid. And so data shows that kiosks actually collect the money better than human beings do. And so we're going to take advantage of that and leverage the technology. And here's some examples of some patient self-checking kiosks. You actually can get one of these for about $8,000. They're not terrible. If you look at how much you're writing off each year, you'll probably return your investment on it the first year. Teleconferencing, I've got multiple locations, so we started experimenting with that, mostly for business meetings and stuff, kind of like we're doing right now. But eventually we'd like to be able to do more with it. We're doing some aesthetics, and, I don't apologize for that. I think it's great. The first thing my diabetic patient does after they lose 70 pounds by working a year and a half with my diabetic nurse educator, and they're off their insulin and their blood pressure pills and their cholesterol pills, is now they've got saggy skin, and we can start addressing that with our Titan laser. They suddenly start getting a little self-conscious and vain. They want their wrinkles taken care of with Botox and whatnot. And we're happy to do it because once they start maintaining themselves in that regard, they don't want to go back to being obese and stop exercising. It just confirms that they are interested in taking care of themselves in a holistic way. And so we support that and we do it, and it helps pay bills. I want to remind everyone, Thursday, April 19th, 2012, is the workshop that the Carlisle Academy of Family Physicians and Health Teamworks are coming together. They're partnering on to help physicians learn some of these strategies for getting NCQA recognition. I've stressed multiple times, and hopefully you saw how important that NCQA Level 3 recognition was for us. Once we got that recognition, it got us into the pilot. It got us into these contracts with payers. It helped us learn workflow redesign, and that helped us improve our efficiencies and really was the difference between us bankrupting or doing incredibly well in an economy when everyone else is suffering and not knowing what to do next. And so take advantage of this. You're not going to get your NCQA recognition in a day, but what you'll do, if you're a CFP member for $200, you can register $250 if you're not a CFP member. Bring two of your staff. Bring a front office and back office person, one of your medical assistants, one of your lead receptionists or billing people who are going to be the implementers of your patient-centered medical model. Come down, and for 8 hours, you're going to go through a program. They're going to teach you all the steps so that you can go back and have weekly meetings and get your NCQA recognition. That recognition costs $1,000. You'll have to pay at the time when you do it. What we don't want to do is apply, and then only get level 1. What you want to do is know what you're doing so that when you apply, you can be level 3 right off the bat like Miramont was and start using that to your advantage in the marketplace when you go to your IPA and your payers. And so learn from Health Teamworks. They are the experts on this. They help people improve their practice. They help me immensely. And then they'll have some opportunities through some of their grant funding to maybe help continue you. I mean, this is really an inside track and a wonderful opportunity. I know physicians look at it and they go, well, it's $200, and if I bring 2 people, that's $400. But, the reality is it takes money to make money. And if you don't invest in yourself, you're just asking to be extinct. Put a little bit of money back into your practice where the payers won't. Build your good quality product. Get rid of that bad food mentality. Build something good, and the good news will follow. And I guess the last statement I have on that is just a call for courage. I give this talk all over the country. I've given it in Boston, in Maine, Orlando, San Antonio. I've given it all all across the U.S. And physicians raise their hand. They'll tell me, well, I just don't see it. That's too much risk, or I don't think it's prudent or even ethical for me to ask my patients to buy prescriptions in my own pharmacy, or to ask patients get their blood drawn in my own lab. And so there's a lot of caution out there. But what I'll tell you is the opposite of cautious is not always careless, okay? Sometimes the opposite of cautious is courage. Ask yourself, are you not doing this because it really is careless or wanton? Or are you doing it because you're afraid? Are you doing it because you're uncertain? We don't know. Is the Affordable Care Act going to be repealed? I don't know. But I'll tell you this, at Miramont, we don't care. We've designed Miramont so we succeed either way. Let's say they lower the eligibility age for Medicare for everyone to age 18. I'm fine with that. I make money with Medicare. We're sustainable with it. Let's say everyone loses their jobs and goes on to Medicaid. I'm okay with that. I'm the only private practice in Larimer County that takes new Medicaid, and we're profitable with that. We're okay with that. Let's say everyone loses their insurance and doesn't have Medicaid. We have a program for uninsured people. I'm okay with that. Let's say everyone gets insurance through exchanges, and everyone has private insurance. We're okay with that too. We get per member per month fees and pay for performance bonuses with the payers. So build your organization so it's irrespective of the markets, but do it bravely, do it smartly. Remember, you're the supplier of healthcare. They need you. They can go to the ER and see an ER doc, but what they're really looking for is a primary care physician. And if you do it right and if you have high quality, the employers see it, the payers see it, they're going to choose you over your competitor, and you're going to do just fine. And with that, I'm going to open it up for questions. So we have our first question here, and it says, did your profile and E&M codes change toward higher codes like 99215? The answer to that is yes. Now, many physicians, rightly so, are concerned about Medicare and insurance fraud. So here's part of the story. A lot of times physicians undercode because they're actually doing the work, but they don't give themselves credit for it. Sometimes they undercode because of lack of knowledge. One of the benefits of having an electronic health record like EMDs is EMDs at the end of the visit, when I go to do my charges, because I sign my notes off at the end of every encounter so that everything's done right as I'm leaving with the patient and it's wrapped up. I know immediately whether I've met all the different criteria for the various aspects of the billing and for the coding. And if turned out, I realized a lot of things I was billing as 99213 should have actually been 214s. A lot of things I was billing as 214s should have actually been 215s. And there were even cases like when patients would come and see me, let's say they're new onset diabetic. That used to kill my schedule. Now I'm going to be an hour behind. I got to tell them how to eat and check blood sugars and give them a glucometer and all that. Now I love that stuff because I sell about half the things that they need to get started, and I can pass them to my diabetic nurse educator. She can spend an hour with them. Patient probably actually gets more information than they used to, and we bill a 99215 plus a 99354, which is the extended visit code, or maybe it's a 56 after. I think one's inpatient, one's ambulatory. But we bill that extended visit code. Now Medicare pays us $180. I spent 30 minutes with the patient. My nurse spent, maybe 40 minutes with them, but we're getting paid for what we're doing, and we're keeping that person from becoming an ER train wreck or a hospital admission. And so the EHR allows you to do better code capture. The other thing is that as we added more ancillary services, we found that we had more things to charge for. For example, I can go in the room, spend 20 minutes with the patient, bill 99213, and we're going to get paid, $60. My nurse can go in for 5 minutes, do an ankle brachial index with a ultrasound probe, which you can buy from China for $150, and take blood pressures with the cuff and a Doppler on the dorsalis pes posterior tibialis of the legs and the arms, measure the ankle brachial index, and Medicare pays $125 for that. Now, why do they pay so much for the 5 minutes that the MA is in the room and not so much for me the 30 minutes that I'm in the room? Well, part of it is if a person needs a revascularization procedure for a profundus femoris artery or something like that, that costs the system $40,000. How many ankle brachial indexes do I got to do in my primary care office to offset that cost? I'll tell you right now, for about every 50 we do, I find someone with bad disease who ends up going to the interventional cardiologist, and they balloon them and stent them. And, that costs maybe, $10,000, but it's not $40,000 like when they have to have a full revascularization. And so Medicare's figured it out. They know that it's cheap for me to pay these. They want them to do them. An interesting thing about Medicare, they don't come and tell us, hey, as a family physician, you can't do this. We are dictated healthcare policy through the Medicare budget, right? So they say, well, Dr. Bender, you can see psychiatric patients. We're just not going to pay for it. If you list depression, a lot of times that gets declined. So what do? We ask, are you feeling fatigued? And the patient says, yes, I'm fatigued. So now I'm billing for fatigue. But again, in my model, what we did is we didn't say we're not going to help psychiatric patients. What we did is we said, we're going to charge some guy rent. He's going to come in. He's going to spend an hour with them. And the psychologist can then bill Medicare, and that's his problem to figure it out. I spend 15 minutes with the patient. I write for the generic Prozac, which we sell in our dispensary. I see him back in 3 weeks for a follow-up. Now, do they feel like I brushed them off? No. Now, I only spent 15 minutes with them, but they got to spend an hour with my psychologist. They leave feeling like I took them really seriously. Whereas if they came in and I spent an hour with them, handing them the Kleenex, listening to the story, finally writing them the Prozac at the very end of the visit, billing a 99214, getting only, $70 for an hour's worth of my time, when generally at Miramont we need to generate about $360 an hour or about a dime per second. Now, I tell the patient, go see a psychologist. Well, how many do that? And so the reality is by spending a little less time with them and delegating in that team-based environment that I've been talking about all along, they actually get better care. They're happier with me. We get more done. I get paid the rent. I get paid more than if I was just trying to do it in the old system. Next question comes in. It says, who hosts the web portal? MedFusion was the original name of the company, and they are an American Academy of Family Physicians partner, and they're an affinity partner. So if you're a member of the FAAFP, then you can get their services at a discount from buying it in the open marketplace. Intuit Health, makers of QuickBooks, basically acquired MedFusion a year and a half ago because Intuit Health decided they wanted to get in the healthcare business. And if you've ever used Quicken for your bookkeeping at home or QuickBooks for your business accounting, that they're a very knowledgeable company, cutting edge, and they do a fantastic job with their website. And I'd encourage you to go to www.miramont, that's miramont.us, take a look at the website, and you can see all the different functionalities that we have there and the different buttons and bells and whistles. And it's very functional, and the patients love it. So I don't see any other questions here. I think we're supposed to go for about an hour. We've got maybe about 7 minutes left. I'm willing to stay on the line if there are any other additional questions. Again, I'm just going to go back to this slide here, reminding people to hook up with the Colorado Academy of Family Physicians, look up on their website the information about the annual scientific conference in Colorado Springs at Cheyenne Mountain Resort. If you've never been there, it's a lovely convention center. Go up just for the day if you want to, and register just for the PCMH workshop. That's $250. First-time attendees get $100 off. If you want to stay for the rest of the conference, that'll be Friday and Saturday, and a little bit into Sunday morning. It's a great time to network. They have booth displays from various vendors that'll be there. Health Teamworks will be there, so you can learn more about them. And then there's CME events. You can get all your CME. Here's another question. What percentage of your profit comes from something other than E&M codes? Well, this is an interesting question because it kind of depends on how you define profit. If you describe revenues, I mean, if I run reclass, for example, we give IV reclass, our charge on that, our receipt is probably around $1,200, but the reclass cost me $1,000. So, the profit margin on that isn't too great. It's $200 or about 20%. Whereas if I have a nurse practitioner that I'm paying, let's just say $45, $50 an hour, if she's in the exam room and she's doing, $150 an hour in E&M coding, now I'm getting a much better return on investment from that service side. So to give kind of a rough estimation, we spend probably about $25,000 a month in supplies, and we're doing probably about $400,000 a month in revenues. And of those revenues, I'm going to guess that about 40 to 50,000 is in ancillary services. I mean, I'd have to get a spreadsheet and kind of work it out, but I don't know if that answered your question, Tim. But that's about the numbers there. I mean, we do hospital work, so we get a lot of E&M coding still. We go to 4 hospitals. We go to 11 nursing homes, and we have our PAs assist us with rounding at times in the hospital, and so that also gives us a little bit of a force multiplier, if you will. We don't plan on using hospitalists anytime soon. We feel we control costs better than hospitalists do, and there's some good data to support that. For those of you who are wondering how the questions are coming in, there is a place where you can write a little chat, and people are sending me chat questions in to look at. Well, our participation is dropping off. I think people are having to get back to clinic and to work. So we're going to wrap it up here. I again would like to thank Eleanor Mills of the Colorado Academy of Family Physicians and Kay, our host, with the web portal here today, the conference servers. Thank you so much. You've been a wonderful audience. And if you have any questions, you can certainly reach me either through the website or feel free to approach me. I'll be at the annual meeting in April and look forward to seeing you there then. Thank you.